Good morning, folks. The Crisis Stabilization Center Subcommittee meeting here on January 20th. I have some information and updates for folks. Let me pull up my agenda. So we will call the meeting to order. Are there additions to the agenda that folks might have request of information at this point? All right, well, obviously that remains open as we have discussions and so forth. So let me know as we continue to go along. And let's see, just in terms of updates, I looked over some of the past subcommittee meeting agendas just to try and compile some information and be able to provide that to folks. We have been gathering data in terms of referrals and admissions to the Crisis Stabilization Center, both the detox, obviously, and the mental health stabilization side. That data gathering actually began in May of 2021, and we've just recently gotten the December 2021 information in. I can talk about this more extensively, but basically the data collection that we gathered specifically has been the referral type, which includes law enforcement drop-off, EMS drop-off, lead, and GRACE referrals, as well as referrals from MCOT, the Mobile Crisis Outreach Team, the DCRs, that would include them. Also referrals, transfers from Peace Health, the jail. We've got a category for all other professionals that are behavioral health professionals in the community. And also, of course, self-referrals, as well as family. And then base camp, we decided that we would include that specifically just to try and sort of break that out as a diversion component. So those are the data types that we collect in terms of individuals that are referred and at least initiated into the process of admission. And then we are tracking it really in regard to whether there's been a decline of admission due to no bed or capacity, declines for medical reasons that the individual doesn't meet the criteria for the Crisis Stabilization Center, and so is then typically referred to the hospital at that point. That the individual may have required the alternate Crisis Stabilization Center service if they maybe initiate an admission in the mental health stabilization side, but are more appropriate for withdrawal management services, so they get referred over to the other side. Obviously, an outcome of the client withdrawing from the referral or the referent withdrawing the referral for one reason or another, the individual requiring a higher level of care. And so that oftentimes is the hospital. If the individual's a level 3 sex offender, or if they've completed their stay and then been successfully discharged to another level of care or resources within the community. And also, of course, if the individual is going to be detained for a 12-hour law enforcement hold, that's something that we're working on, and I'll talk more about that process this year. That the individual is currently in treatment, or that there was a miscellaneous outcome discharge. So those are the data collection types and the outcome of those referrals, tracking those. What we've done is created a spreadsheet with those factors included, and the providers then submit that monthly outcome to us, usually within about a week following the month that they've been documenting. And we've created a workbook that will summarize that information and give us some information just in terms of being able to track that, the number of referrals from a specific referent type, that sort of thing. I can give you, we had a little bit of a different spreadsheet that was occurring in 2021, and I expanded it to include some other factors that I listed here for 2022. Didn't change the spreadsheet significantly in hopes of being consistent with the providers. And so we've compiled the available 2021 data. As I mentioned, that was data that we collected from May, given that the facility had opened in January, but collected from May 2021 through December 2021. At this point, with Compass Health, they received a total of 773 referrals over that 8-month period. 339 was the largest reference source, and that was the self-family referrals. The next largest was 288 referral transfers from Peace Health. 47 referrals came from MCOT to Compass Health during that time frame, and 48 from other professionals. So I was just kind of working from the highest number of referral source to the lowest. And then of course there were some others, but they were fairly low in terms of the numbers coming from there. So predominantly at this point, or 2021, self-family, Peace Health, MCOT, and other professionals were the referral sources for Compass Health. They had a variety of utilization. Bed utilization is really based on a basis of 16 available beds in a day. In a typical month, as our capacity is 16, as I think folks know, and then dividing that by the actual number of beds that were utilized. That varied a little bit in 2021 because of construction challenges, security camera issues, and so forth. So utilization wasn't always for every month 16, figuring on 16 available beds. But so that varied just a little bit. But it was figured into the analysis of that. And at this point through 2021, Compass Health had a 63% utilization of available beds. So that's some summary information there. As far as the detox side, Pioneer Human Services, they had 1,662 referrals over that 8-month period. The overwhelming bulk of those referrals were self and family referrals at a total of 1,506 of those 1,662. There were 116 Peace Health referral transfers in that total, and 20 of the referrals were from other professionals. There was a total of 9 referrals from Base Camp to the detox program. Pioneer Human Services had 78% utilization of available bed dates. And as I made reference, that's based on the capacity at that point in time that, again, for them varied a little bit for a number of reasons, whether it was workforce, staffing, availability issues, et cetera. Some fairly recent information. I did get contacted by the manager of the Pioneer Human Services Detox. There were 2 individuals that are doing rapid tests for COVID at this point, and there were 2 individuals that they had tested that had been admitted that did show positive for COVID, and they transferred those individuals to the isolation quarantine facility, and are standing by at this point with a total of 7 individuals that are currently admitted. They're not admitting at this moment, but hoping to by the weekend, once they've done some retesting to obviously contain that process and so forth. Go ahead.
Quick question, or 2 questions maybe. So the numbers of referrals, mostly family and Peace Health, if there's any from law enforcement or EMS, would that show up as the MCOT, or we're getting that maybe indirectly through self and family?
It's possible, absolutely, Todd. And I do have a specific law enforcement referral category that hasn't been a significant number. And I'm sorry, I don't actually have the data right up in front of me, but I could send it to you. It's fairly small at this point. And at least from my perspective, the reason really has been that in July, obviously the implementation of House Bill 1310, the challenges that that are there specifically relative to transport that an individual, there was some, obviously some clarity that really needed to come about relative to law enforcement transport of individuals, whether that was on a voluntary or involuntary basis. But I think that that's really impacted that. There's a lot of work that's being done around that, and I'm sure that Under Sheriff Chadwick can make reference to that. We also have really great involvement from the Sheriff's Office in our Crisis Stabilization Center Advisory Committee. And so there's as well as Bellingham Police Department in regard to attending those meetings and just talking that through. I do want to talk a little bit more. I had it a little later in the agenda, just in terms of challenges as far as admissions and just the protocol and process of admissions in the facility relative to first responders and law enforcement. And, again, Under Sheriff Chadwick and Mike Hilly can certainly offer some information about that. Doug, I see that your hand's up.
Yeah, good morning. Yeah, I'd agree with that, and that kind of confirms my discussions with our staff as far as referrals and utilization, and a lot of it comes down to capacity and just the folks that we're trying to divert don't meet the criteria. And I know there was when we were planning this facility and looking at having the ability to take people on an involuntary basis. Obviously, that's still in the works. And then, as you said, last summer, we had some changes to legislation. And I know there's currently some bills that are looking to fix some of that, specifically when it comes to ITAs and those situations, more of the civil commitment situations. So real quick, Perry, when you were talking about the utilization on the mental health side, are we able to take the full 16? I know there were some limitations on capacity just due to staffing issues.
We are at, pending COVID, as I had made reference to, we are at a utilization of a maximum capacity of 16 on both sides. They do report, both of the managers do report in if there's going to be some variance for any reason, staffing or whatever it happens to be. And that's included in the, in the data that we actually collect. But currently, we have reached the ability to admit at a 16 capacity on both sides. So great question.
Yeah, and I think that was one of the concerns early on. It's great to add 32 beds, but I think at the end of the day, that still is not near the capacity to meet the need out there.
Very much agreed. And again, an issue that I want to talk about and some actions that have been taking place that are affecting that specific thing. I think even maybe not more so, but that is of a focus and concern for me is the streamlining the process of admissions for both law enforcement and first responders to the facility, just in terms of the individual meeting criteria, the time frame for admission, and et cetera. I may hold on that particular topic to discuss it specifically with some other components, but want to return to that. So what I'm saying is that, at least from my perspective, it is in part, certainly the limitations that law enforcement has been experiencing and figuring that whole piece out. But another significant component that we're looking at and wanting to do work on is literally the admission process, and that being very timely for law enforcement and first responders, and working with the providers in that regard. So I'll elaborate on that here just a little bit later in our discussion.
One more question on. Oh, sorry, from my colleague.
Go. Oh, yeah, Michael.
Hey, good morning, Perry. Is that 2001 data summary available for the committee, or is that?
I don't have it. I can send it out to folks. More than happy to be able to do that. I don't have it to share on screen at this point. My apologies. I can do that in our next meeting. So
no worries. Do they break it down by payer, or whether or not they have Medicaid, or
Right. Great question. They don't do that for us. And part of my reasoning here in terms of, request of data is, as folks are, pretty aware, we basically are making a request relative to the data collection from our providers based on the lease agreement and a memo of understanding to provide that information. So I'm cautious about the level of detail in terms of data for two reasons. One, just in terms of consuming their time in that regard. And two, just in terms of the challenge of more data and the detail of that data, conceivably accuracy, because that is, of course, coming from the providers at that point. I know, Michael, I think that the BHASO also gets data from the providers. Is that accurate?
Yeah, we actually get data on the non-Medicaid capacity and utilization, but we will, and maybe this is for discussion later on in the agenda, getting kind of monthly deliverables around the involuntary admit.
Right.
For the state. And so if there's a way to kind of, streamline all this data reporting so it's not too much of a burden on the provider.
Right. And I think, and I know you've been super helpful. I have a meeting scheduled with Michael and the providers, actually Compass Health, relative to, and I'll speak about the proviso funding this Friday. And maybe, Michael, we can do this offline, but I have been curious about the possibility of obtaining some data from you and maybe compiling that in some way, as opposed to necessarily adding it to the spreadsheets that we're collecting, but whatever would work best in regards to collecting information, and that being, as simple as possible, would be great.
Yeah, I agree.
Todd, did you have a question as well?
Yeah, I don't know if this is easy to answer right now, but just in terms of those utilization rates, you had 63 and 78%. Is that, does that work for the people, Compass Health and the other contractor? I mean, are they getting enough clients that they'll want to keep renewing their contracts with us?
Right. I think that there's a couple of components to that. One, obviously covering their cost, because their full payment for services comes through Medicaid billing, and also through additional funds. And Michael can elaborate on that, but from additional funds for non-Medicaid individuals through the BHASO. We've talked about that funding being challenging just regards to the rates, obviously, as well as the challenge of a kind of a fee for service basis, as opposed to more of a firehouse model, if I can use that terminology, that it's a 24/7 process. And so that brings up some challenges. But I think the upside of that is that it does bring a level of motivation for the providers to keep their census high, in order to have an impact on that cost. So that may be short-sighted on my part, but I'm glad at least that component is there, because I think that those aspects are hugely important as well for that motivation to be there. In regard to, in comparison, providers, especially with a higher level of care that we've created within the Crisis Stabilization Center, medical monitoring on the detox side, and obviously the medical process on the behavioral health stabilization side, bringing with it also a higher level of liability. And so, providers being, liability avoidant, in terms of admissions and so forth and so on. So, I think that is something that we need to continue to pay really close attention to, and that I'm having pretty extensive conversations with relative to, and it's the reason, of course, that I shared the numbers, the utilization rate, particularly for the mental health stabilization side, not being at a level that I think compensates the provider in terms of their cost, and working through that process. I think I can stop here and maybe jump into it a little bit, that we've been having some really specific conversations with Compass Health in that regard. And they have created a work group within Compass Health to review a couple of things, and I'm going to mix some challenges, but the ultimate goal here is obviously to increase the utilization rate to be able to compensate cost, and so forth. But also, I really had some very specific conversations around our primary and priority admissions are diverted individuals, whether that be arrest, emergency department, those kinds of, or utilizing honestly services that maybe aren't the best targeted services for those individuals. And so they had, in response to the concerns and honestly the data that I'm sharing with you, what they did was convened a group to take a very specific look at the WAC requirements in terms of admissions, their certification, and streamlining that process specifically for law enforcement and first responders, as the feedback that we've gotten is that the process is somewhat arduous and time consuming for those individuals, and the goal being that law enforcement or first responders can make contact with the facility, ascertain whether there is a vacant bed, number one. And if there isn't, then they're going to, do what they need to do at that point in time. But also that the admission process is very short for the law enforcement involvement or first responder involvement, and they can move on and do the things that they need to do in terms of responding to calls. So Compass Health's response to my raising concerns in regard to their current utilization, as well as just feedback that we've received from law enforcement and first responders, is to take a look at, okay, what is actually slowing that process down, and what steps can we take to increase that utilization, as well as decreasing the time that law enforcement or first responders spend there to obviously increase the referrals in general. There is also a work group that is occurring, and I expect to get some feedback in this regard tomorrow, that there is a fairly lengthy process for completing the certification for involuntary commitment. Not to be confused with our sort of standard involuntary that would occur by the designated crisis responders, but this is that 12-hour law enforcement hold that can occur. And so they are pursuing certification for that. And as I said, we have a meeting with the BHASO and Compass Health tomorrow, just in regard to talk about their time frame and the processes that they've gone through. It's a fairly involved process with the State Department of Health to obtain that certification, and really trying to figure out if there are some differences between the certification that the provider would pursue relative to ENTs, a much higher level of care that occurs for Compass Health as a provider, evaluation and treatment centers, and the certification that is necessary for law enforcement 12-hour holds. So those two things are somewhat different, and we're hoping that that certification is less involved. It certainly should be, because the requirements are less. I'm hoping anyway, the requirements are less for a 12-hour law enforcement hold than they are for an individual that needs to be admitted for involuntary treatment and stay for, they're evaluated constantly, but stay for a much more extensive period of time. Jack and Michael got there at the same point in time. Shall I choose Jack since he hasn't shared, Michael?
Either way, I want to make sure I understood something correctly, and I may be biased because I've been listening to this for a long time, but for at least a decade, we've been talking about quick law enforcement handoffs. Am I correct in understanding you're saying part of the utilization problem is, despite all of our efforts to coordinate that with the sheriff and EMS and local people prior to opening of the facility, that you're saying we still have a significant problem in the drop-offs? And that's affecting census?
Right. I would say absolutely. I think that it's a combination of House Bill 1310 implementation, and also the process of admission, the time frame that it takes the provider to admit the individual. So I think it's a combination.
Okay. So my question is, the providers were supposed to do a 10-minute admission. So that was the goal all along.
Mhm.
I've sat and I don't know how many meetings where that was the goal, 10 minutes for law enforcement. How close are we to that? Because I understand the House bill impact could be significant. I understand COVID could be significant, but the extent to which the infrastructure problem is on our provider, that shouldn't be happening, because they should have been set up all along to do that 10-minute quick handoff. And I mean, we talked about this for years, Perry, and I can't tell you how many conversations there have been. So it bothers me a lot if that, I don't see how in the contracts or in the interaction with the providers that wasn't a high priority. They needed to understand why we're trying to retool it when it should have been as basic as having a bed.
Right. Yep. And I think it's a great point, Jack, and absolutely noted. I won't attempt to answer in terms of what time frame are we at, because I haven't asked that specific question. I certainly will, but I don't want to answer, obviously for them. I think in reality, because this is a somewhat unique, setting, in reality, you're absolutely correct. It was always the plan and the intent and the discussion. And then when the reality hit, I think that again, some components began to occur and develop, and then in pushing towards that, the responses oftentimes were around, the individual is not appropriate. They need a higher level of care. It takes this, period of time to do the admission. However, one of the things that I absolutely have noted in, I'll talk about this a little bit more later, but our Crisis Stabilization Center Advisory Committee meetings is absolute efforts on both sides for the managers to say, I know that the law enforcement need to get out of here. And whether or not we can complete this admission, let's just go ahead and evaluate whether or not this person needs a higher level of care. And if they don't, send law enforcement on their way. And yet that admission, as more information is gathered, may not be successful, and they need to transport the individual to the hospital. But really, we've achieved that initial goal of getting law enforcement, and first responders on their way. That is very much the focus and discussion, predominant discussion in the Crisis Stabilization Center. So it is in no way, shape, or form ironed out at this point. And it's a arena of great focus for me in the meetings that we continue to have. I've literally created subgroups once we have the crisis stabilization, the advisory committee, which includes law enforcement and first responders and the providers and other folks. It's a large enough meeting that working through specific details hasn't been successful. So I've created subgroups to continue to focus on that very thing. So you're absolutely dialed in on it.
Oh, okay, here's what I'd like to request. Not trying to go too back in time, and that's not always useful. I was chair of this the first 2 years. Jerry DeBruin, who represented EMS at that time, was very clear on this. Bill Alpha was very clear on this. I'm sure Doug shares his point of view. The goal was 10 minutes. The goal was a 10-minute drop-off. And I think the county or whoever's holding our providers accountable backing off on that standard, unless it's COVID or something, we shouldn't do it. And if there's some reason the providers don't understand the standard, I think we need to retool it, because the issue, and I'm coming now from an incarceration prevention reduction paradigm, because this is a subcommittee of that group, not anything else. And with that lens, if we're trying to reduce the impact of incarceration, a critical element is a really fast drop-off, and backing off in any way, shape, or form is not in the interests of the task force. So I've said enough. I know you hear me, but I think it's really, really important. And I would say it's a high priority that has to be addressed. And if it can't be, if it has to be 20 minutes or 30 minutes, that needs to be communicated, and law enforcement and EMS need to understand. But hopefully it isn't. Even the facility design with the things in the back were in large part for this fast drop off. And absent that, much of the benefit, I think, that comes for incarceration prevention and reduction is lost, because then we have the same problem we did with the old detox, where law enforcement and EMS didn't want to use it because of the time constraints. Thanks.
I agree. Yep, I agree. We've looked at a couple of components in terms of saying, basically the admission process, for example, the information that they're required to gather and, and et cetera, for an admission to the mental health stabilization side, for example, takes up to actually 2 hours. Now, I'm not talking about law enforcement involvement for a 2-hour period of time. And so we're taking a look at, and I'm hesitant to throw this out, but one of the considerations that I've had is to say, well, we don't need to hold law enforcement, for example, because this person might not be able to be admitted in the idea of using law enforcement for that transportation. They are very expensive transportation and have other responsibilities and needs to be able to meet. So would it expedite the situation to say, don't worry about that. We can address the transportation issue if the individual needs to go to a higher level of care or something of that nature that doesn't involve law enforcement. Let's then ensure that that time is minimized. You got the information from law enforcement that you needed to get. You can send them on their way and then proceed with whatever licensure requirements are for the admission process. So taking that into account. So in other words, that is some of the thought process that I'm taking is saying, okay, so that's an obstacle, fair enough. Then we need to bring another facet into this in order to accomplish this goal of a 10-minute drop-off for the reasons that you just listed. So those are some of the thought processes that I'm beginning to have and having, meetings and communication with obviously Mike Hilly and others that are a part of that. So absolutely noted. Michael?
Jack kind of hit some of the theme that I wanted to address, but I apologize, Perry, if you've already addressed this in the data review, but does the data suggest that there's a delay in admissions for people that are eligible for admission, like they meet the criteria and there's no exclusionary criteria, or are these a lot of the barriers of getting into the facility or because there's some sort of an exclusionary criteria that's preventing them from getting in?
Sure. No, it's a good question. I have not drawn that information specifically from the data that's being collected. This information is coming more from the important feedback that I'm getting from the community paramedics, as well as law enforcement. There haven't been an extraordinary number of drop-offs, at this point because of 1310, during this time frame. But mostly this is coming from feedback and, individual feedback from community paramedics and law enforcement that are bringing up that concern and that discussion. So it's more anecdotal, at this point than it is data and the specific. We're not, for example, measuring the specific time frame that law enforcement drop-off, for example, requires for the law enforcement. So hope I answered the question, Michael.
No, you did. I think I'm just kind of trying to explore if there's a specific exclusionary criteria for admission that seems to be a major barrier for folks getting in, or just looking at common themes and trends around the clinical criteria that they use for the facility.
Right. One of the things that has come out of the Crisis Stabilization Center Advisory Committee is really we've been working specifically on communicating the admission criteria, and honestly found that it was more helpful to take a look at the admission exclusion, so that the training process, and communication process with law enforcement and the community paramedics, EMS, was more on, hey, we can't take an individual that's on oxygen. We're not licensed for that. It's illegal for us to do it. So, that's an exclusionary criteria, and really focusing on that and putting that information out there for our first responders to save time, in that regard. More often it is historically, and this isn't a large number, so I'll put that out there, individuals are combative or assaultive, and that ends up being an exclusion piece, and those seem to be the events that require a longer period of time because there's hesitancy to have law enforcement leave when the individual, is not at that point in time open to, the admission.
And is it my understanding, or am I understanding it correctly, that the admission criteria or the exclusion criteria would or would not change with the new involuntary triage certification and that police drop-off capacity for the 12-hour hold?
Right. No, so it's a great question. I think that predominantly the very limited exclusionary criteria, if we, term it that, it remains the same by virtue of the individual is not able to function with daily, ADLs. The individual is assaultive or combative, at that level, is violent, reaches that particular level, or has some other medical component that is not treatable at the level of care for the Crisis Stabilization Center, and so those wouldn't change. I mean, we remain focused on those, and that continues to be a training process to make sure that it's like, hey, we're not able to do this. The first stop should certainly be the hospital in that given situation. So I think that that's a component of ongoing, communication and training. And we have a really good audience, in regard to that, as far as the Crisis Stabilization Center and communication with the Sheriff's Office and BPD at this point in time. So yeah, no, really good question. I don't think that will change, but I am very interested in this process of, as Jack was making reference, the goal being a 10-minute period of time for law enforcement or first responders to be involved.
Yeah. The only reason I asked is, I'm not an expert in this, but just knowing that a part of the involuntary 12-hour hold, of course, would be their, in very rare circumstances, utilizing seclusion and restraint. How that interplays with their ability to manage behavior, manage more acute behavior. That's more of a provider question and a training question, but just wanting to kind of explore that idea. But I know Doug has his hands up, so
yeah, no, and good question. And if one of the things that I will say about this is, at least the way that I'm understanding all the components that are going to come together for this RCW 1031-110 law enforcement 12-hour hold is essentially the law enforcement individual, making a decision because the event that occurred was a low enough level of crime that it can be considered for this. That's kind of one aspect. And then the discussion with the individual saying, listen, we've got a choice here. I can take you to jail, or I can take you to a much better place, obviously, and having that brief discussion, and the individual essentially being open to, yeah, I would prefer to go to the Crisis Stabilization Center. So hopefully initially, the individual is, open to that process and engagement and understanding, listen, if you're not willing to do this, then, alternative B is jail. So that, obviously facilitating the individual's motivation to be involved there. From there, if the individual, and again, this is my understanding, and we'll talk more about this, I know, tomorrow, but if the individual is there, the drop-off occurs, we're in the process of admitting, and the person says, you know what, now that law enforcement's gone, I've changed my mind. They would actually say, okay, as we had shared with you, we're going to make contact with the law enforcement, and the fact that you're now refusing to remain at the facility, and they would not go hands-on, isolate the individual or whatever that process is at that point in time, but they would immediately communicate with law enforcement and say, listen, Perry Mowry, you dropped him off, but he left. And so we're informing you of that information at this point. And so my understanding of RCW 1031-110 parameters, is that is actually the process after, using motivational interviewing and, the other aspect of, hey, can we get you some food? We've got a good bed for you here. There's no problem. We hope that you stay longer than 12 hours, but your obligation is 12 hours at this point, and you're understanding that. And then that is re-engaged with law enforcement at that point.
So the goal is really not to use seclusion or restraint or any hands-on interventions with anyone that's combative or unwilling to engage in treatment during that 12-hour period.
Indeed, they have the resources because we do have an isolation, area and that sort of thing, which they can use. The individual is observed at that point in time, and there's a number of steps that go on there. But that is really for the individual's safety, as opposed to, again, my understanding, and I can get greater clarity on this, but as opposed to some form of medication to sedate the individual, or those kinds of processes that are commonly used in the evaluation and treatment centers, which are, a higher level of care. So that is my understanding of the allowances of our police officer hold and that certification that they're pursuing. Otherwise, the certification requires far more extensive staffing of a physician that is on staff, and the cost obviously increases dramatically at that point.
I mean, even just historically, as a BHO, when we were managing much more closely the evaluation and treatment centers that were involuntary facilities, I mean, the goal was always zero seclusion and restraint. I mean, that's the goal across the board.
Right.
I think I'm glad to hear that the providers are kind of, I mean, we can have more conversation, but I think
Sure.
it's a good goal to have. So.
Yep. Okay. Thanks. Doug?
Yeah, I just want to add on to, I agree with Jack, and he's obviously been involved in these conversations longer than I have. I know the sheriff, was on the original committees when these discussions happened. But yeah, the 10-minute, I mean, to get law enforcement to be able to drop off and get back out in the field and respond, especially for the county, they're driving a long ways from other portions of the county, and oftentimes we have minimum staffing, so it's important to get them back out in the field, available to respond to those 911 calls. And again, I don't have the numbers with me, but just anecdotally, and I kind of warned of this as we were having discussion about the crisis stabilization, that we didn't go down the same path that we did with the triage center, which on the connected there to the work center at the other end. And I can't tell you how many times as a supervisor, when that facility was running, to call and try and get somebody in there and told that, well, are they cooperative? Well, right now they are, but they weren't. And it's kind of this up and down. And we all know people in mental health crisis go through various phases. And I think that in my conversations with our staff and the chiefs and the lieutenants and the supervisors is what was happening. And that was my concern, is if they're being turned away either because of no beds, so it's a capacity issue, or those exclusions, they're, are they cooperative? Are they combative? If not, we can't take them there in short order. If they find, if there becomes a pattern of not being able to take people there, they'll look for other alternatives, and that may be just a referral. And then again, we've got the hospital and we've got the jail. So I know, part of, as Jack says, the whole idea is with the Incarceration Prevention Task Force is to divert these folks from the jail. So my concern is if we don't change that soon, it's going to be a facility that law enforcement and other first responders will get used to not even attempting, just because they've been stonewalled so many times trying to get people into the facility.
Yeah, it's a great point. And one of the things that I'll say about that, Doug, is that, again, sort of returning to the fact that other than, the physical drop off of the individual, and also gathering some really basic information from the deputy or officer, there really is no need for the law enforcement personnel to stay. And The other piece that we're absolutely focused on is the ability for first responders, law enforcement to call and say, is there a vacant bed? Because if there isn't, then, we can make that whole discussion less than 30 seconds. And, the law enforcement professionals can make that decision about, okay, so, what am I going to do? And we don't have to waste the time of, I actually stop there and then discover that there is not an available bed. So we're very targeted on that, just in terms of that orientation towards limiting the involvement of law enforcement other than that drop off. And again, that's where I was really coming from when I was talking about this concept and idea of, well, you brought him, so you're the transportation to leave here. And it's like, I think that's problematic. And we don't want to use, that's very expensive transportation and likely, unnecessary. So really looking at that particular factor of it as well. Mike?
Thanks, Perry. And I just wanted to echo a little bit of what Doug Chadwick was talking about. And Perry's described some of the challenges. I do want to let you know that we worked out a specific set of protocols and an inclusion-exclusion criteria for EMS, because we have to train some 600 EMTs and paramedics to be able to work in that protocol. Actually, our doctors agreed with it. Their doctors agreed with it. So the protocol piece is in place. The challenges are coming back to what Perry talks about, which is knowing from day to day if you can get in the facility. And if you can imagine that you've got an EMS provider at 2 o'clock in the morning trying to advocate for a patient, and they have to go through this big process, and you're coming from Kendall to get in, there's just no way we could give a blanket, a ticket for EMS to do that on a regular basis, because it has to be consistent and reliable, just like they're mentioning. So I worked with the healthcare authority the other day on this. We've figured out how to get the reimbursement for those facilities, pre-authorization to get there through the system and embed that. But once again, it's more about this idea of the 10-minute handoff, and they just can't do that right now for several reasons. I think as we've talked through this, there's a couple of ideas that Perry and I, and working with Rob Sullivan over at Pioneer, that might be able to knock down some of those barriers. But I agree, the longer that it goes, the less likelihood we're going to be able to get any type of diversion. And for EMS, the promise was diversion from the ED, a better narrative for the opioid overdoses, the different places for the alcohol OD that night to go, et cetera. And I know on the Pioneer side, they have a high level of care that they can provide, just short of an ICU type of patient for a polydrug overdose or some of those specialties, but they are prepared to take it. But once again, at that intake point, EMS just needs to be able to make that assessment, advocate for the patient, do that 10-minute drop off and get out of there. And if the patient gets worse and needs to go somewhere else, now the hang up is that they don't have the ability to transfer unless they call 911 back. So a lot of this is, there have been some patients been diverted over, but they all went through the ED to get that referral to get in, because they have to sit in the ED for so long as they navigate all that. Those are kind of the challenges, and I've been super reluctant to turn this loose in EMS right now, because they'll go over and drop off and they'll have all these problems, and of course the phones will be ringing off the hook for the complaints about it, and it'll further diminish the reliability of it. So but I do want to let everybody know that we're working hard for that diversion piece, and I can't think of any way that we divert mental health right now, considering all the challenges of just getting into that side of the facility. But the SUD side is the most promising for at least me right now, in trying to get some success on those diversions.
Yeah, Mike has been really key in terms of that communication, and most of the points that have been talked about here, and communicating with the providers and saying, okay, so what are the action steps that you're going to take? Where do we go with this? This is the goal that we need to reach, et cetera. Michael?
Just a quick question for Mike. So is it the medical clearance that's hanging things up from the provider perspective, or what's?
Yeah, no, not really. Actually, I'm very confident that our EMTs and paramedics can make a medical decision on their behalf. And that's exactly what the protocols are about, which is we engage a patient. Oh my gosh, they look eligible for the diversion center. We'll do a quick medical exam on them, even do an EKG if we have to, and determine that they're not at risk on some other aspects of, for example, a polydrug overdose. And I'll use this as an example. If a person tries to overdose on something and die by suicide, things like Tylenol, other medications will kill you really a lot faster than a basic, say, a heroin overdose in a long time. And so a Tylenol overdose, for example, has to go to the hospital because it's a complicated medical management. But the heroin overdose that goes over there, no problem. Alcohol overdose, even a meth overdose that could go in there. But we're pretty confident the decisions made in the field will cover that medical clearance. And interestingly, PD really doesn't have to do that because they're not making a medical decision, they're making a law enforcement decision. But when they do go to the facility, they'll get a second medical exam in there as well. So so that's sort of where the safety area is on it. But EMS can comfortably make those decisions without problem.
Thanks, Mike. That's kind of what I was assuming, and just going to explore that.
Other discussion on this point or or clarification in terms of the steps that we're taking. I feel confident in the discussion points and goals that we've set, the communication that has occurred with the providers at this point about, reiterating, as Jack had mentioned, the discussions that we've had historically, and updates to that regard. I went as far actually in this regard after compiling some of this information of reaching out to the chief operating officer of Compass Health and having communication saying, is there anything that I'm missing here? Because this is the goal. This is what's been discussed. This is what's needs to be on the table. And I know that a group is convening and addressing these pieces. But if there's something that I'm missing, please bring that to my attention and reiterate the information that I've shared with the Crisis Stabilization Center staff, the supervisor, and then, just happen to have this relationship with the chief operating officer as well. This was a fairly recent conversation, but just wanted to make sure that everybody was fully cognizant of the feedback that I'm getting, the challenges and frustration that is being experienced at this point. And then also, of course, as I mentioned, bringing those components and saying, okay, if transportation is an issue, then let's talk about that. What other, challenges and issues do we have that we can work through, and let's do that PDQ is basically the message that that I've been offering. So any other thoughts, input on this particular topic? We've just started the second year. It opened, the Crisis Stabilization Center opened in January 2021. Obviously with construction and, and the other aspects that we all know about that brought challenges about. We've been through that, and I think that some of the other obstacles have actually been addressed successfully. And so just really see this as a key point in time. There's another factor that is also at play here that we do we had some initial proviso funding to support providers, just in the fact that Medicaid billing would not necessarily cover the cost and so forth. So just as a reminder, there was some proviso funding that was available for 2020 and 2021 that is utilized. There is also now proviso funding that is available for 2022 and 2023 in the amount of $200,000 each year. But this proviso funding is specifically oriented towards the certification and process of 12-hour law enforcement holds, what we commonly make reference to, not fully accurately in my opinion, perception, that is the involuntary status. But these 12-hour police officer holds and the certification necessary in order to accomplish that. As I mentioned earlier, that Compass Health has convened a specific team pursuing this certification, working with the Department of Health, Healthcare Authority in that regard, and the components that are necessary for that to be in place. If I recall, this type of arrangement, the 12-hour hold, ability, the involuntary aspect is unique to the Whatcom County Crisis Stabilization Center. I believe that there was one other facility in the state that was also pursuing this, but that was a little while back that we had, some of those discussions and so forth. And again, I'm beginning to get updates just in regards to the pursuit of this certification. I don't have a timeline right now, but one of the things that the proviso funding does specify is documentation and data for individuals that are admitted in connection to this 12-hour police officer hold, law enforcement hold, and so that is actually on the table as well. And obviously, Compass Health is knowledgeable about that particular component. So I mentioned that I have a meeting with the BHASO and the provider tomorrow to get an update in that regard. And so anyway, wanted to make sure that I can I can share here if folks care. I can send this information out. The proviso language says authority to contract with North Sound Behavioral Health Administrative Services Organization to establish Whatcom County Crisis Stabilization Center as a pilot project for diversion from criminal justice system, appropriate community-based treatment. The pilot shall allow for law enforcement to place involuntary holds for up to 12 hours for persons placed at the facility in accordance with RCW 1031-110. The amounts provided must be used for the cost of the services at the site not covered under the Medicaid program. It goes on to talk about the authority and so forth, but that's the proviso language. I can certainly provide it to folks. And we're having, thanks to Michael, we're having regular meetings just in talking about implementing this process. And my hope is that that implementation is imminent. And we move forward on the other considerations of that we've been discussing, up to this point in time. Thoughts, comments, questions about that piece? All right. The other thing that I wanted to provide as far as information is we have a couple of meetings that are occurring relative to the services at the Crisis Stabilization Center. One of them is the Crisis Stabilization Center Advisory Committee that I referenced earlier. That committee actually meets on a monthly basis. We do have law enforcement representation consistently, as well as first responder. Mike Kelly attends, I think, every time. And so we have good input there. We also have attendance and input from Grace lead staff, so that we're making sure and bringing that component to the table, as well as obviously providers. We do have a Crisis Stabilization Center quality improvement document that's been put online. One of the things that we began to run into was if there was a challenge in terms of an admission or an individual had left against medical advice or something of that nature, that we would sort of get these reports, or people would bring sort of verbal reports to the Crisis Stabilization Center Advisory Committee meetings. And I just really felt that it was important to document this information. And so this is a quick online, you can put information in that doesn't violate the individual's personal health information, but gives us a little bit of a reference so that it allows myself and some of the other staff at the health department to follow that up with the individual that actually submitted the online form, as well as then circling back and communicating with the providers to get more information, because a lot of times what we were running into was kind of a he said, she said situation, and it really wasn't helpful, in my opinion, in coming to some kind of successful conclusion in that regard and looking for patterns. So we follow up any of those quality improvement documents by connecting with the individual that submitted it and also the providers, and then bringing that information to the advisory committee as well and discussing that process just to, again, identify any patterns or challenges, responses to those challenges, and holding a level of accountability. So I think that's a really positive aspect of the advisory committee, and it's open to the community. We've communicated that. We have meetings that the health department facilitates with behavioral health providers and crisis responders, and we continue to reiterate that it's like, this is available, please communicate with us. But we do ask that folks provide us with some specific information other than, obviously information that identifies the individual by name or anything of that nature. And so the date and, the event that occurred, pretty interesting. The differences between the information that's initially provided and some of the outcome of investigating that process a little bit. And so it continues to reiterate the value of those improvement documents, quality improvement documents as they're submitted. So that's been a really positive aspect. So the Crisis Stabilization Center Advisory Committee meeting meets once per month. I think it's an important meeting. It's a fairly large meeting, and so oftentimes we will identify and communicate information or identify the concerns that we've talked about here, and then have actually created some subgroups, particularly one that we've been working on with the detox side. That we meet every 2 weeks. Mike Hilly is a part of that, as well as Jackie Mitchell, myself, and Rob Sullivan, who is the Director of Services for Pioneer Human Services. Interestingly enough, one of the challenges that we have there is a little bit too much of a good thing. As I had mentioned, through various levels of utilization and so forth, they were near an 80% utilization. And so one of the challenges that we face at the detox side is that they are at capacity, which is a good problem to have. And I'm thrilled about that particular aspect of it. But we are beginning to focus into the fact that we want to ensure that the individuals that are admitted to detox are our priority individuals. That is, those are individuals that are being diverted from arrest, incarceration in the jail, use of the ED, those kinds of things. That's a little more of a sophisticated challenge just by virtue of the fact that the staff, are oriented towards admitting individuals that meet the criteria. And that can vary, to a certain extent when it comes to detox. Most of this is self-report, of course, as the individual is sharing the information about possibly their usage or length, time, etc. But one of the things that we've been doing, for example, is to ensure that the staff are trained in regards to who is our target and priority group, as well as also developing options, a bit challenging in this time, as folks can imagine, but developing options of, okay, I don't have to say no. What I can say is, I have an alternative for you that I'd like to, have you consider as we've gathered that information and et cetera. Now, that doesn't mean that the individual couldn't be referred to an inpatient treatment setting or something of that nature, but may be better served through a shelter setting, that sort of thing. Historically, one of the things that felt like we were running into, not here at the Crisis Stabilization Center, but earlier in the triage facility, was that the number of admits would increase dramatically when the weather turned. Individuals were looking for a place to sleep, a dry place to sleep, understandably, as well as food, that sort of thing. Not necessarily a good utilization for, the extensive staff that are there. So have been really pleased with the involvement. I felt like it was important because there are very different admission considerations and challenges between detox and mental health stabilization, that I needed to work with those groups separately because they had unique challenges that they were, dealing with, in that regard. And I think that that's actually been pretty successful. So I expect that utilization number for detox and mental health stabilization, obviously, to increase. And am more than happy to then address the challenge of we are at capacity, we don't have a vacant bed, honestly being the goal. We deal with that problem when we get to that problem, I think, to a certain extent, as far as law enforcement and first responders and drop-offs. But as Mike Hilly had shared, the alternate destination for EMS and et cetera would very quickly, I suspect, would very quickly fill vacancies at the Crisis Stabilization Center. And I would be reporting that to this committee, at that point, and the challenges that are there. So we wanted to work on the priority clients and that training to continue to be in place with the staff that are in process of the admissions and et cetera, and not wait until we ran into that situation, because I think that we can arrive there fairly quickly, given the need that is out there in the community. So I wanted to update you in that regard. As I had mentioned, I'll just sort of wrap this with those really kind of in my notes anyway, the advisory committee and developmental committees that are being convened at this point in time, with specific action plans that are coming out of those, was just a reiteration that I had reached out to the upper structure of Compass Health and said, I've got a challenge and I need your help. And the time frame is very short here for the reasons that we've talked about before. I expect some feedback within the next week, if not by the end of this week, from that individual in terms of the support that I can expect to receive from them in being a part of that meeting, and or bringing components to the meeting and saying when we'll be successful with this particular piece. So that's an additional step that I've taken. I have one last piece of information on my notes anyway, relative to the agenda, and that is folks may recall that there was a process of there was some concerns in terms of decorating the facility to make it a little more inviting and settling for individuals that are struggling with crisis. The decision was made that murals would be painted because hanging art is a risk, in terms of it conceivably becoming a weapon. And so that process was actually initiated by Ann Deacon prior to her departure with a group known as Makeshift Art Space. That funding and contracting and et cetera process has been completed, and the mural project is scheduled to initiate with some of the first murals being painted right towards the end of the month. I have coordinated connection between the managers at the facility and the staff that are local artists in Makeshift for the mural project's progress. And I'm getting feedback that that's been scheduled and that they're prepared to begin that process and work through patience and those kinds of components in order to accomplish that. So staff are excited about that, as well as obviously are the artists. So we'll be able to update you in that regard as well. And that is the extent of the information that I have. Can I answer any other questions? Have you felt heard? Are there steps that you can offer in addition as far as recommendations, suggestions?
I want to say I appreciate having the referral numbers, and I don't know if that would be like something we get just at the end of the year, but maybe updates as we go along would be. It's really good information to have.
Yes, we do obviously collect the data on a monthly basis. Excuse me, and I do have that available. The workbook that we put together actually summarizes that data in the summary page and graphs it. So it will give a year to date percentage and that sort of thing. As we compile the information, it automatically does that. And so it's available at any point in time. And I know that we are meeting, I think this meeting is scheduled quarterly. I can certainly send that information out more often.
Quarterly would be great. Just, it's maybe just a brief couple minutes update for our quarterly meeting.
Certainly, absolutely. I will absolutely do it during the meeting. My point is that it could be available at shorter durations of time if folks want to make that request of me. Maybe that's the best way to do that. We keep it in the iDrive, on the health department iDrive, and I can access that information and have a discussion about that or forward that information. The workbook itself is a little cumbersome and challenging to forward, but the summary information is not. I appreciate the challenges that this brings, and have hopes in terms of my ability to to address the components. There's no question that the details that we've talked about here have been communicated to the providers, and sort of standing in between that to continue to support the providers and obviously support the first responders, my first priority. And we have a good framework for being able to do that. The Compass Health responses, that are imminent, are going to tell, in my opinion. And I've certainly passed along that thought process and information to everybody that I can speak to in Compass Health, in that regard. So I think that the next quarter will be very telling. Both in the data numbers, although I am cautious about managing just as a manager from spreadsheets, but it certainly is helpful to bring the right questions to the table in regard to where we're going. Any other information or agenda items that folks would like to bring up for the good of the order? All right, we are to the point in our agenda in relative to public comment. Jill, will you help me with this?
Yes, we don't have any attendees today.
Well, I'm shocked. I felt like this was a very important part of my day, and I was hoping that maybe somebody would be willing to attend. I think as we continue to be more successful, we'll have more attendees. Kind of thing. By the way, just as a kind of a wrap up on this part, I am reporting information in the behavioral health subcommittee, as well as the combined legal and justice and behavioral health committee in regard to the activity at the Crisis Stabilization Center, predominantly the admission process and utilization. So I do bring that information to those subcommittee meetings as well. All right, thank you. Anything else for the good of the order?
Thanks, Barry.
Thank you, Barry.
Very much appreciate folks attending. Thanks so much for your time today.
Yeah, thanks, Barry. We
Have a good
appreciate you
week.
doing the heavy lifting.